Welcome everybody today to our first in the CWORPH webinar series for our year 2 projects. My name is JP Leiter. I direct the Center for Public Health Systems at the University of Minnesota, and I'll be your moderator for today's webinar. As I've mentioned here, this is a webinar to talk about the Public Health Workforce Research Center year 2 projects. The PHWRC is funded by HRSA and CDC and is conducted by the Consortium for Workforce Research in Public Health, which includes 6 universities: University of Minnesota, Columbia, East Tennessee State, Indiana, Johns Hopkins, and the University of Washington. We're funded by HRSA and CDC as the National Public Health Workforce Research Center. There are 9 health workforce research centers funded under this program in total, and ours focuses on the public health workforce. Let me go through a couple pieces of housekeeping as we jump in. To ask a question, you'll be able to bring up your Q&A webinar in the Zoom application and ask questions there. We have a chat in case it's needed, but let's try and use Q&A to keep things clean if we can. We do offer closed captioning during the webinars. You can manage that through the bottom of your Zoom screen. We're going to distribute the slides via email shortly after the meeting to all attendees, and the audio and video will be recorded, so if you need to review this later, you'll be able to do that. Please subscribe to our mailing list if you'd like to hear more, and we'll include that in the chat. All right, so Rachel, are you able to bring up the slide deck, please?
Yes, give me a second. Sorry, Nicole's power got cut unexpectedly. So, oh, here she is.
It's all right. Nicole, are you back with us? While you bring up the slide deck, either Nicole or Rachel, let me introduce you to today's speakers. So we're very pleased to have 2 presentations. One on evaluating a minimum data set to characterize the public health nursing workforce, and one on distributing the distribution of local health department nurses and nurse leaders relative to local demographics. So for our first presentation, we will have Bekemeier and Paula Kett talk with us. Dr. Bekemeier is a nationally recognized public health systems and practice-based researcher with a particular focus on the structures and practices of state and local health departments in relation to health outcomes and reducing disparities. Dr. Kett is the assistant director of the Center for Health Workforce Studies at the School of Medicine at the University of Washington, and deputy director of workforce focused on health equity. In our second presentation, Dr. Balio is a research assistant professor at ETSU and focuses on the intersection of rural health, health policy, and public health. All right, with that, let's get started on our first presentation. Paula, if you would like to run your slides, that is just fine. Thanks, everybody.
Thanks, JP, and thanks, Paula. I'm going to kick us off here. Thanks for having us. Paula and I will be the ones presenting today, but there are others that have been involved in this research, and we'll mention them along the way and at the end. So thanks so much. So next slide. So to get us all on the same page regarding what even is a public health nurse. So here's the definition that has been established by the field. The public health nursing is the practice of promoting and protecting the health of populations using knowledge from nursing, social, and public health sciences. So when you think of a nurse whose so-called patient is a whole community or population, that's what we think of as a person who's doing public health nursing, and whose responsibilities are to work with and meet the needs of that community or population. So examples can include anything from clinical interventions and oversight to developing community partnerships, facilitating cross-sector collaboration, involvement in data monitoring and reporting, policy advocacy, et cetera. So, but increasingly recent research is demonstrating that public health nurses bring unique and high value to the public health enterprise. When they're leaders of health departments, for example, they've been found to have a significantly positive influence on their own staff proficiencies and on community health outcomes. Other research is showing that public health nurses bring unique skills, have brought unique skills to the COVID response and to emergency preparedness and response. and also in understanding and addressing health inequities. But in terms of the size of the public health nursing workforce, they've long been the largest segment of the public health workforce. And even as they're among the smallest of nursing specialties more broadly. But the number of public health nurses is really dwindling. They're repeatedly the hardest type of staff for public health agencies to recruit. They've seen by far the deepest decline among public health occupations and health departments in recent years. And these dwindling numbers may be due, at least in part, to difficulties related to describing the practice of public health nurses, including what they do and how and where they practice and where and when they're needed. So with the public health workforce development efforts underway, and JP kind of touched on those, the need for more robust methods for identifying public health nurses has really been underscored as necessary to understand their distribution, to identify areas of need for more public health nurses. And you'll hear some of that from Casey later, and to address recruitment and retention issues. And finally, to guide academic efforts to strengthen educational pathways for nurses going into public health. But there's real big difficulties in assessing public health nursing numbers and distribution. There's variable measurement of public health nurses depending on the survey used. This includes national and state surveys of the registered nurse, the broad registered nurse workforce, for example. They're surveys conducted by individual states and in national surveys of nurses. And some of our own research has found how varied these measurements are when trying to identify public health nurses among those data. And most prior research regarding public health nurses has been conducted using looking at governmental public health agencies at the local and state level. That includes PHWINS and other public health workforce interest and needs surveys and other surveys. But so those state and local public health surveys identify public health nurses limited to health departments. So when a public health activity can be carried out in a variety of settings, especially when public health systems are organized differently in different states and communities. So public health nurses have been thus typically identified by setting, in particular, by setting alone. And that really doesn't say much about public health nurses in terms of their practice or to guide workforce planning efforts. And then finally, studies rarely have included public health nurses in federal agencies, such as the U.S. Public Health Service Commission Corps, where there's over 1,200 public health service nurse officers serving as part of the governmental public health workforce. So in our study, and given this national decline of public health nursing numbers and their key contributions, we're increasingly finding that they make to communities, there really is this urgent need to gain a deeper understanding of where these nurses work, what they do, how they address, and how to address these workforce development urgent needs. So the aim of our study was to illuminate the nature of the federal public health nursing workforce as part of this governmental workforce, in particular around the U.S. Public Health Service Commission Corps, in terms of their demographics, work settings, and also functions and activities. And then through this survey work, we would pilot test and assess the accuracy of a set of job function and activity questions for effectively describing and measuring the public health nursing workforce more broadly. So these survey questions we were really trying to get at being able to measure what these nurses do and not just where they practice. And then that could be used in future studies and through refined workforce surveys through which we can accurately describe public health nurses. So the survey, for the study, we adapted, existing national survey questions. And we work closely with the current and past Public Health Service Chief Nursing Officers, Rear Admiral Jennifer Moon and Captain Aisha Brooks. They were really critical to this work. And the survey had 4 main sections. Of course, sort of nursing education background, and then position and job information. We collected demographic information, and then in particular, questions about job roles and functions. There were 12 functions we included, and these were drawn from previous surveys and the literature, and also from the public health nursing scope and standards. And then we adapted these with help from national experts. And then conducted the survey in early 2024, inviting every nurse in the U.S. Public Health Service to participate. And I'm going to hand it over now to Paula for the findings.
Great, thanks, Betty. And just before I jump into the findings real quick, we also, just for our analysis, this is mostly a descriptive study. We did do a little bit of a comparison, a sub-analysis, looking at primarily clinical and primarily non-clinical groups within the U.S. Public Health Service nurse respondents. And a lot of that was because in responding and filling health system gaps, U.S. Public Health Services nurses may more often be in clinical settings or primarily clinical settings more often than we might find public health nurses in other areas, such as in local and state health departments. And so we wanted to look a little bit at whether or not functions differed among more primarily non-clinical nurse officers. And I'll get to that in the results a little bit, and we'll show you. So overall, we had a great response rate for a survey. 47% or 565 nurse officers responded. And we found that most identified as female were over 40 years of age. Less than half of the sample identified as white, approximately 30% as African American or Black, and 14% as American Indian or Alaska Native. And as I'll get to at the end, this is much more diverse with regards to racial identity than we find in the general nursing population or broader nursing population. We also asked participants about their highest nursing degree. A bachelor's degree is required for the role. So everybody had that, but almost half of our sample reported a master's in nursing as their highest nursing degree, and 12% reported having a PhD or a doctorate in nursing practice. On average, respondents reported having worked as a nurse for about 18 years and in the U.S. Public Health Service for approximately 12 years on average. And most reported having an assignment in a Health and Human Service agency, most often either in the Indian Health Service, in Department of Homeland Security, or in the Federal Bureau of Prisons. So with respect to the reported functions and activities, again, we asked about 12 function areas. In the entire sample, most reported functions in these top 5 areas. So health promotion and protection, clinical interventions, care coordination and case management, policy and advocacy, and research, evaluation, and quality improvement. And we also asked respondents whether or not they thought that the proposed function and activity questions accurately described their work, and 88% agreed that it did. So generally found that this was, that this covered the spans of their work. So in that comparison between primarily clinical and primarily non-clinical groups, and those in the primarily clinical group were those that reported working in either inpatient settings or ambulatory care settings. So the primarily non-clinical group had settings often in HHS agencies, but also some in local and state health departments as well. And we found that the primarily non-clinical group more often reported functions related to research, evaluation, quality improvement, policy and advocacy, and enforcing laws and regulations. And it's not that those in the primarily non-clinical group still reported clinical interventions as a function. You can see that on here in the comparison. But we find in doing this, this helps us identify more distinctive functions that may be more distinctive of the broader public health nursing workforce. So overall, we found that nurse officers in U.S. public health services are more diverse, more educated than the general nursing population. Also, a higher percent identify as male. And we really just note this because it may offer opportunity for learning in terms of recruiting and retaining a more diverse nursing workforce more broadly, which is something that is really needed. We overall found that the proposed function and activity questions accurately captured the responsibilities of public health service nurse officers. But we did find that there may be a need to clarify some of the questions. About 12% of respondents selected other when given the option for either their function or activity when describing their role. When looking at those responses, most could be recategorized into existing function and activity options. But this helped us see that some of the options may have needed to be expanded. Definitions may have been helpful, and also potentially some additional guidance on breaking down their role into functions and activities. But overall, given the national decline in public health nursing numbers and key contributions that they make to communities, there's really an urgent need to gain a deeper understanding of where public health nurses work and what they do. And as such, we really need better workforce measurement approaches that focus on their functions and activities rather than setting alone. And so in light of that, we really have these two major recommendations. One is that we'd recommend using the questions piloted in this study for future assessments of the public health nursing workforce in conjunctions with surveys which are assessing the larger public health workforce. And if anything, using really the top 5 areas that we noted here, such as health promotion and protection and policy advocacy and development. And then we would also recommend modifying or adding questions specific to respondents' work functions when measuring the broader nursing workforce in national nursing workforce surveys. And this can help us better understand the role of nurses overall and the functions and activities in their work and better capture smaller specialties. So thank you very much. I want to thank our team, and as Betty said, our U.S. Public Health Service colleagues, the nurse officers who contributed to the survey. We currently have a paper under review, so watch out for that. We want to acknowledge our funding, which was from the CDC and the Health Resources and Services Administration. And also we did provide a few references related to some of the background that Betty mentioned at the beginning. So when these slides go out, you can have access to some of the papers that we note here. And with that, I will pause. Thank you so much.
All right. Thank you very much to Betty and Paula. We're going to shift over to the second presentation for today, which also focuses on public health nurses, but from a slightly different perspective. Are you all seeing the slides okay?
Yes, thanks.
Great. Thanks, Paula. Okay, so we're going to jump into talking about this next project, which really looks at the need for and supply of public health nurses across the country. And like Paula and Betty's project, this was also supported under the same funding mechanism from HRSA and CDC. And this study was led by a group of us at the ETSU Center for Rural Health and Research. So for the background, Betty and Paula already went into a lot of the detail around sort of what public health nurses are and the vital role that they play in our communities and within their agencies. So we'll go through this relatively briefly. But PHNs are one of the largest public health occupations in the field, with more than 90% of local health departments employing at least one RN and nearly 30,000 public health nurses across the country from some measures. However, echoing sort of what Betty and Paula shared, there are many different ways to define public health nurses, and they participate in a variety of services and activities within their organizations. So while many are focused on more population-based activities, some are involved in providing direct clinical services, and others are involved in leadership roles or other roles that may be somewhat independent from their public health nurse training or their nurse background, but bringing that lens to whatever they are doing. And while public health nurses are among the largest group of public health workers, there's still considerable challenges in recruiting and retaining public health nurses, and their placement and roles differ across the country. So that brings us to the purpose of our study, which is to understand the need for and supply of public health nurses across the country, but at the local level. For this project, we were really focused on county level data and are ultimately interested in providing evidence and data to inform resource allocation to support the role of PHNs and agencies across the country. So we had several research questions for this study. First was, how do we measure the need for public health nurses at the county level, and how does the need vary? Second, we jump into the distribution or supply of public health nurses across the country. And then finally, we combine these two, the need and supply, to identify public health nursing deserts or priority areas where there's relatively high need for public health nurses and relatively low supply. Our sample for this study is a little bit different for different aims based on the data that's available, but primarily all of the data focuses at the county level or was adjusted into county level data. We use a combination of publicly available data sources about communities and about populations from the American Community Survey, the Area Health Resources Files, data from the CDC and from CMS, and then we supplement this data with data about public health nurse staffing from the 2019 NACHO profile. For the assessment of need for public health nurses, we ended up developing an index of need, which includes most counties in the US that have data available. And then for the second and third research questions, we narrow down our sample to only counties that have at least one local health department that participated in the 2019 NACHO profile and had data about public health nurse staffing. For the analyses, we started with developing an index or a composite measure of the need for public health nursing, which we're calling the Public Health Nursing Need Index. And then we compare the relative need and staffing of at the local level to define public health nursing desert priority tiers. And finally, we look at some bivariate analyses to think about or to understand the associations between the presence of a high priority public health nursing tier area and community and agency level characteristics. So for this index, we used the CDC's social vulnerability approach as sort of a foundation for the methodology for developing this. It used various measures that are associated with potential need for or the role of public health nurses, which was guided by data and evidence in the field as well as experts. And the CDC's Social Vulnerability Index provided a useful foundation for building this index because there's no clear outcome measure for which to validate the index against. It also weights all measures and domains equally, so there's less of a concern of any given measure or domain sort of skewing the data. And it's all calculated on a relative percentile ranking. For our index, we required that the included measures were available nationally at the county level and on a continuous measure. Importantly, they also, the measures in the need index were totally independent from the local health department context or the public health nursing supply. For this process, we took each individual measure and ranked and then summed them within domains and then again ranked and summed across to ultimately calculate an overall index on a percentile scale. Our index was ultimately comprised of 16 different measures across the 4 domains listed here of demographic indicators, economic indicators, healthcare context, and healthcare status and outcomes. All of these were either already measured in a way that higher percents indicated higher need, but for the few that were the inverse of this, we reversed those scales to align with this direction. So getting into the results, this first map shows our results from our first research question, looking at the national public health need index across the country, with 100 or sort of those darker shades of blue or green representing the higher need and the lighter representing the lower need for public health nurses. Importantly, all of these are relative measures of need, so the lower index scores don't reflect no need for public health nurses, but reflect relatively lower need compared to other counties across the country. Next, we looked at sort of mean and median need measures by HHS regions. The HHS map is here as well. We identified that regions with the highest need included regions 3, 4, and 6, which are kind of the mid-Atlantic, southeast, and border states. And while this is helpful from a national perspective, it becomes relatively less useful for individual states and for planning within states. So because of this, we also calculated a state version, which ranks counties within states and helps to really show that variation that does exist within a given state. This is especially useful for states that rank all relatively high or relatively low on the national index. So it's a little bit harder to understand what might be going on within your state from that national perspective. So here's the state version of the index, which is available on a decile scale from 1 to 10, where within every state, we're ranking all the counties in that state. 10, or the darker greenish blue, again, indicates the highest need within states. So from there, the next step looked at the correlation between the need and supply for public health nurses. Given the lack of consensus around sort of what the right ratio is for public health nurses per population, and the understanding that the need for and role of public health nurses may actually differ by community characteristics and other contexts. Because of this, we considered a relative measure of supply of public health nurses, where we again used staffing ratios, which were RN FTEs per population, and then we put that on a percentile scale, similar to what we did for need. So this chart looks at the relative need, which is that PHNN index, and the relative supply, or the percentile of PHNs per 10,000 population, to look at the correlation between these. And while the chart is a little bit technical, I think it does a really good job of illustrating the lack of a strong correlation between the need for and supply of public health nurses at the local level. Each of these dots indicates a county across the US. There's about 800 counties that are reflected within this. So we see that these are really sort of all across the board in terms of the relationship between need and supply. So because of this, or from this, we identified and defined 3 different priority tiers, which are displayed here in each of the boxes. So priority tier 1 is here with the highest need and lowest supply. Priority tier 2 is sort of above or below the 50th percentile of need and supply. And then priority tier 3 is all other counties in the US. And similar to the relative need, this follows a similar concept where the ones that are in priority tier 3 are not a priority, they just are a lower priority compared to these other tiers that have higher need and lower supply. And that brings us to looking at characteristics of the agencies and communities served and the associations with being a higher priority tier. So we identify that several characteristics in particular are associated with higher priority tier status. And that includes governance structure, the agency size measured by full-time equivalents, accreditation status, and a few measures of community level racial and ethnic composition. And then lastly, we have a map identifying where those priority tiers are and where the counties are that were able to be calculated within this priority tier part of this work. And all of this data will shortly be available on GitHub that can be downloaded or used by states or other groups. So bringing us to sort of what all of this means and thinking about some of the limitations and next steps of this work. First, for limitations, we have several things to consider when sort of interpreting and using these findings. First is that there is missing data within this. The index omits measures that may be related to public health nurses or need for public health nurses, things like vaccination rates, but that don't have consistent nationally available data at the county level. So we were restricted to measures that sort of fit those criteria. Next, the priority ratings were limited by the availability of staffing data coming from the NACHO profile. After that is what I mentioned on sort of the right public health nursing staffing ratios. There's no agreed upon right ratio, so therefore this is a measure of relative need and supply. Again, relative measures of need and supply. These are based on sort of percentile rankings. They're not based on absolute thresholds or sort of absolute measures of need or supply or priority, but still provide some direction to prioritize resources. And then lastly, the PHN full-time equivalents were based on the RN FTEs from the NACCHO profile, which may not reflect the actual individuals, roles of individuals with nursing training, and only considers a very specific background for public health nurses. So to think about sort of what these results mean and how they might be used, we really identify that there's high variation in both the need for and supply of public health nurses across the country and within specific states. We identify that there are some variations that exist regionally. And then most importantly, we find that need and supply don't correlate that strongly across the country. So this again sort of helps us to identify areas that have high need and low supply that may be used to use a data-driven approach to allocate resources for training, recruitment, or retention of public health nurses, or to help support local agencies. And findings from this might help in allocating these vital resources, including those that are made available through the Public Health Infrastructure Grant and other funding mechanisms. So that's everything that I have for you all today on this specific project. And I think that JP is going to sort of walk us through a little bit of a Q&A session.
Thanks, Casey. I'll invite all presenters to come back on camera. We're going to go through some questions that have come in your presentations, but also if folks have more to add in, please do. Let's start first with one for Paula and Betty from a public health prevention and nurse who works in treatment. They said, I see a demand for infection preventionists where employers seek nurses with a public health background, such as an MPH. Is it possible? Is it a possible market transition for PHNs to become focusing on IPs?
I mean, no reason not. I think that that kind of gets at a little bit of what Betty and I have talked about. We're talking about at the beginning of wanting to identify, that typically public health nurses have been nurses working in governmental public health with the title of public health nurse, something, somewhere around that. And that there may be other nurses doing public health work outside of that space that we aren't identifying right now using those approaches. And so a nurse working for an employer in infection prevention could very well be doing public health work, and easily, if they had been a public health nurse, transition into that, they could do that from other nursing backgrounds as well. So I don't know if you have anything else to add to that, Betty.
Yeah, that fits what Paula with the work we've done in this recent public health nursing enumeration study using national nursing data, broadly captured data around RNs. But a person in that kind of role would have been captured, I think, Paula, don't you think, in terms of that enumeration study, because they would be doing functions that we would have captured that are indicative of what we identified as a public health nurse.
Thank you. All right, this one is a question about the index. I'm going to combine two questions, Casey. Were tribal health departments included in the index, and should states like Massachusetts have an asterisk because they define services differently? Should centralized states like Florida have an asterisk since they share across jurisdictions?
Thank you very much. So first, we only used local health department data from the NACCHO profile. So that does not include tribal health departments, which is a function of the data that we have available, but would be great to be able to expand to other health department types in the future, and to have even more data about local health departments across the country, as there are many that we don't have data on, and some of this data is starting to get a little bit old as well. More complete data like Betty and Paula have is something that could be used to expand this, especially as we get more and more robust data in the future. And regarding the different sort of state structures, this was a bit wonky to sort of handle and deal with. So we ended up collapsing health departments that served either multiple health departments that were in the same county. And then we also had to deal with counties that, or health departments that serve multiple counties. So for this, we have staff that could be shared across multiple counties. And then we also have sort of this uniform assessment of county level availability, which may not actually be how public health nursing services or their work is actually distributed within those counties. So there is a little bit of some differences in how these things are measured across the country based on how public health departments are structured across the states.
And I can add, JP, that's a little bit of some of the work Paul and I've been doing too, is to try to get at what Casey's describing, that health departments are structured differently in different places. So sometimes the public health nursing work that is in a health department in one setting, as say, for example, a school nurse or doing school health services, is in a health department in one setting and is outside of the health department in another setting. So trying to capture that public health nursing work and those people, relates to advancing both what Casey described and what we're talking about, what we presented.
Thank you, Betty. A question for all three. Could the shortage of nurses be due to more health departments using CHWs that are cheaper?
Yeah, good question. I think that would be more, we would need to look at more newer data around that, because I don't think in the data that we've been looking at, there have been as big an influx or trends around CHWs, and that'll be something interesting to look at. And I wouldn't doubt if there's a potential relationship there. I think in my mind, public health nurses have an important role in working with community health workers and as part of a team. That said, I do think part of the decline is also as over the last decade, as health departments are doing more work and have had more of a focus around public health 3.0, this population focused work. I do think there's a bit of a disconnect between we're doing less clinical services, so we don't need public health nurses. So I think there has been some sense of that, which has perhaps been to our detriment as we sort of more and more identify public health nurses as having this kind of unique influence and work in these other sort of population level areas. So I would attribute the data we looked at, but more to maybe the public health 3.0, as well as, of course, the ongoing recruitment retention issues that health departments have long talked about in terms of public health nurses.
And worth highlighting that both you and Casey and research not talked about today have highlighted the decline of public health nursing kind of in total over the past 10-15 years. So a lot of that does predate the whatever influx of CHWs there are now.
Right.
And I would just add, I think part of it too is really this defining roles more clearly. Like Betty said, both public health nurses and CHWs have really important roles in public health, and getting a better sense of where public health nurses best placed and where a CHW is best placed and how can they overlap is an area that we need to do more work in and get a better understanding of. So,
Casey, a question for you. Would you talk about special hardships that exist for providing rural public health services? For example, how much more are rural public health nurses required to drive per week than urban suburban PHNs? Do you think this influences recruitment? And I'll add, or retention.
Thank you so much for this question. And this is something that Betty and Paula, I'm sure, can also speak to in more detail. Yes, I'm sure there are many reasons why it is more difficult, or there are at least different constraints on recruiting public health nurses in rural settings, and really just recruiting in general in rural settings can be quite a challenge. We have seen sort of this shift towards thinking about things like drive time, not only for sort of patients in the healthcare sector, but for staff in the public health sector as well, thinking about how much people are actually, or how much time people are spending driving and what the distance is and what the costs are associated with that. So I think that is certainly something that should be considered and is likely related to some of the challenges that we see. We did include a measure of rurality within our need for public health nurses index, where higher levels of rurality were sort of contributing to higher levels of need for public health nurses. I think part of this is probably driven by that sort of those challenges that exist, but also knowing that in rural areas, public health nurses are often serving sort of different roles and more varied roles. Oftentimes they are serving multiple roles within their organizations, and they're often in places that tend to have sort of lower other access to clinical services and other sort of social services and social support. So I think there are lots of reasons to think that the need and the supply and the recruitment is really challenging in rural. Betty and Paula, do you have anything to add to public health nurses in rural?
Paula?
Well, I think oftentimes how do I fully answer that? I think oftentimes we know that rural areas are more often staffed by nurses, right? So like if you're looking at who even the public health staff is in rural areas, it's usually nurses or nurses and one other person, because they can kind of cover the gamut of clinical needs. And like Casey said, these gaps that exist are different in rural areas than you might find in an urban setting, and may require more of the kind of crossover of clinical and then systems expertise that public health nurses have. And on the flip side, I think they're very small. And so in terms of kind of the where they're located as opposed to where they're working can be really different. But we've talked to a lot of public health nurses around the country, and in rural areas, and Betty may have other pieces to add. A lot of them are from there or have come back from other places to work as a public health nurse in those areas. And I think there is a strong level of commitment outside of also isolation and needing a lot of support. So.
And they're definitely harder to recruit and retain, et cetera, in rural areas. But by the same token, you're more likely, a nurse director of a health department is more likely to be in directing a rural health department. So you're more likely to find them as leaders of local health departments in rural areas. And Paula's own research, has shown that they've had an outsized influence, those public health nurse leaders of rural local health departments, as well as their public health nurse staff, I think have an outsized influence in rural areas, and make them that much more important. And getting back to where you're showing what you're talking about, Casey, in terms of the need, right? I do think in rural areas, they have a huge role, and at the same time, they're very hard to recruit and retain.
Mhm.
And some of those local public health nursing leaders of those health departments, as they retire, that's a problem too. In particular, if they have a particularly strong influence on health outcomes and other positive influences in communities.
Betty, let me ask a follow-up from your question that we got in the chat. So with the significant turnover in nurses, we're constantly thinking about what are the training needs, competencies for folks that are on the job or that would come in. Could you talk about the specific competencies needed for public health nursing compared to clinical or research environments? And do you find that the nurses come to public health, governmental public health, with those competencies, or are they developed on the job?
Paula, you get ready to add to what I'll say here. But I would say yes and no. if they've got a bachelor's in nursing, then that delineates them from a nurse that does not have at least a bachelor's. If you've got a bachelor's of nursing, you would have had community health content, public health nursing content, et cetera. Now, it may not be great. It could be good, it could be not so good, that content. So, but they should have had some basis in that. That said, I think what nurses bring in terms of competencies to these roles are, you know, they ought to be skilled and well-trained in communication, in working with their so-called patient or community, and having some of those, and the holistic sort of broader kind of system focused view of how to improve people's health. I mean, that's the training that nurses get. So I think they bring that, in some of the research Paula and I are doing, you know, of course that varies tremendously. They are getting a lot of on-the-job training, or another problem with public health nurses is they're going into small agencies quite often. There's very seldom is there much of a, definitely not much of a, there's seldom a residency, support for residency or training, individualized training, as they start their jobs. So, and with high turnover, there's less mentorship or support in that regard as well. Paula, what would you add?
Yeah, I think when we've spoken to public health nurses, a number of them say they had no idea this existed coming out of nursing school. Most who in research in recent those who've became nurses kind of as their first degree, rarely do they end up in public health nursing as their first job. But we are finding that for people who maybe go into nursing later, that a lot of them and are public health nurses, they're kind of oriented towards nursing or wanted to become a nurse because they wanted to become public health nurses. So we see this divide among kind of maybe newer, younger nurses, not necessarily knowing about public health nursing coming out of nursing school. And I think that there are nursing skills that you learn in nursing school that aren't necessarily shown how they can be applied in the public health nursing space. So nurses come in with requisite competencies like communication, like systems thinking, understanding the big picture, et cetera, that you do get training for in nursing school, but needs help with translation and maybe understanding how that's applied in a public health setting. I think the other piece that we really find is important and that nurses need more support on is data and understanding data, that's not necessarily something that they might come out of nursing school with, but that's a really important piece of applying or understanding the community that they're working with and the needs of the community they're working with and how to help support problem solving. I interviewed somebody a while back who said nurses use the nursing process, right? So the nursing process is this assessment, diagnosis, planning. About, here I am like not remembering all of the pieces, but there's a process that nurses learn that's really helpful whenever you're going into a situation and deciding what needs to happen. And public health nurses learn how to apply that at a community level, whereas you learn that at an individual level in nursing school. And I think that helps distinguish them both from other types of nurses, but also other types of public health workers in the job that they do.
Thank you. A question now for Casey. It looks like 2 of the highest need areas are in region 4 and 6, southeastern and south central states. These are also some of the same states that typically show the lowest rates of public spending across the board. How does political climate factor into the public health nursing workforce research?
Yeah, this is a great question. I think this is something that we see quite a bit in public health systems research in general. When we look at things regionally or by state, we definitely do see that those areas tend to have highest need in a lot of different measures, not only highest need for public health nurses, but in sort of many other measures, and generally lower investment in the public health system. This is something that sort of continues to be an important point. We also see differences in just how public health, state and local public health are organized within these different regions. We did include measures like Medicaid coverage in our index, which were meant to sort of capture a little bit of the differences in political context through things like Medicaid expansion. But there are certainly sort of other ways that we probably should think about how political context really relates to these types of questions and this type of work. And to think about what the solutions and sort of how these findings may be used, given the differences in political context. If anybody has any suggestions or sort of other thoughts on that, we'd love to hear those too.
All right, let's follow that up with a question that I think is somewhat charged, but in a good way. We have talked in this presentation about how over-reliance on how PHNs and potentially community health workers might contribute to strain, burnout, turnover. The question is, do researchers suggest only or merely that more PHNs are needed, or that more specialists like policy analysts, health educators may be needed to allow PHNs to maintain their clinical focus?
I'll take a first crack at that. I do think, you know, public health nurses will be the first to say that they are a part of a team, right? That they often will resist kind of highlighting that they're special or that they bring something special. But because they are really a part of a team. So to say, do we need these other folks or is it a public health nurse is really hard to answer. That said, I think, you know, what we are finding, if we weren't finding Paula and I and other researchers more and more that they do bring something unique. They do have a kind of special relationship with supporting the workforce, with community health outcomes, with some of these other being able to have a wide variety of skills that they can tap into in different spaces. I think if we weren't finding that, we wouldn't be pursuing this as actively, I think. But I think those other people are important, and I definitely think community health workers, the sort of rise and role of community health workers is an important one. And I think it's great to see that. And I think it's a really excellent role for public health nurses to be working with and community health workers as part of a team and having a role with them. So I don't know, I'm not answering your question as directly maybe JP as you're asking it, but it's a hard one to answer kind of explicitly.
Yeah, I would agree. I think that it kind of gets back to that role definition that I was talking about earlier. And I don't think we have a good enough sense of, I think we're just starting to get more detail around what are public health nurses doing in these settings and and then being able to answer like, what pieces are really mattering for the community health. And I think sometimes it's a little nebulous, really trying to get at that from the side of really what Casey was measuring, that public health nurses are meant to be doing work that's responsive to community need. And so that's going to look different depending on the community that they're in. But I think that when we can start to identify or isolate that a little bit more, we can get a better sense of like, what are the gaps that are still existing, and who else do we need kind of on those teams in terms of potentially specialists or people with skills and who are doing activities that aren't really best meant for the public health nurse. Because I think Betty and I will often talk about this idea of vaccines, that a lot of people think about public health nurses as giving vaccinations, and that's really not a great use of their skills. Other types of workers can do that actual clinical work, and using their skills on more of a systems level in terms of coordinating and communicating, collaborating, partnership is better. But again, we need to do more work there to really figure those pieces out.
I agree with what Betty and Paula have shared. I think also just going back to the fact that in many agencies, anybody, not just public health nurses, are really filling multiple roles and not just one role. So I think that applies to a variety of other folks as well. But having more focus on sort of a narrower set of activities or responsibilities is likely going to be more efficient in many cases. So there are probably many instances where public health nurses are doing 5 different jobs. And if they were just able to focus on their actual PHN related job, they probably would be able to get a lot more done in that space. So there are certainly things that can probably come off anybody in public health's plate and be sort of reallocated to somebody that may have more appropriate training for whatever that item or task might be. And we also, especially in small and rural health departments, we see that it's really hard to reach sort of economies of scale and to reach efficiency in a lot of these types of spaces. So I think that's something to sort of continue working on and trying to figure out how we can really recruit for people that can fill the gaps that we need in a local agency at any given time, which may not be the same across the country or across time.
And I think one thing they can do too is move a little more effectively between the public health and healthcare system. Especially in rural areas where there's, where they might be the only game in town. And that can be of great benefit to the health departments as well. JP, I think you've got a message for us.
I do. So we are winding down. I want to thank everybody for joining, to you, Betty, Paula, Casey, for your great presentations. And I'm taking a moment to highlight that we've got 3 more webinars in this series. The second webinar is on February 5th at 10 a.m. Central. We'll drop a link in the chat and put stuff up on social media in case that's easier. And then please note there's a corrected webinar 3 link. We received some notes that there were issues with the first. So with that, I want to thank everybody and have a great rest of January. Bye now.
Thank you.